We'll be covering cyanotic congenital heart diseases now, starting off by tetralogy of Fallot. And the reason that makes this disease a cyanotic problem is because the shunt will have the blood flow from the right side to the left. So deoxygenated blood is coming into the oxygenated side. So what makes this pathology cyanotic is essentially the four presentation that it needs to come with. These four are basically what gives it the name tetra, from the number 4. The first thing that we see is a very large ventricular septal defect. Large, very large, to the point that it does not cause any murmurs. Usually in the acyanotic ventricular septal defect, we hear a pansystolic and a harsh murmur. In the case of tetralogy of Fallot, the abnormal sounds that we hear have nothing to do with the ventricular septal defect because of how large it is. The second finding that we have, and the second thing that we need to see present in order to label it as tetralogy of Fallot, is the overriding of the aorta. The aorta in the case of tetralogy of Fallot could be coming from both more or less the right and the left ventricle. It's not just coming from the left ventricle. You can see that it's leaning a bit towards the right side, so it's not completely coming from the left side. The third thing, and probably the most important, is the pulmonary stenosis. Now, it's not stenosis in the actual valve. The stenosis that happens is a bit more in the infundibular part, or basically a bit below the valvular region. And then finally, we have the right ventricular hypertrophy, which we can see in the X-ray as the appearance of a boot-shaped appearance, which is very distinguishable, or a distinguishable feature for tetralogy of Fallot. So the four findings are the enlarged ventricular septal defect, or a very large ventricular septal defect, overriding of the aorta, pulmonary stenosis, and finally the right ventricular hypertrophy. Now, when it comes to pulmonary stenosis, this is the thing that makes the pathology cyanotic. Now, the presence of a ventricular septal defect usually is supposed to make the blood go from the left to the right, because the pressure in the left side is higher than the right side. But there should be something, for it to be cyanotic, there should be something that makes the pressure in the right side higher than that in the left side. And this is the pulmonary stenosis. The narrower it is, the more the problem is going to be cyanotic. Initially, if the narrowing is very mild, we call it a pink tetralogy. You will have all of the four features, but the stenosis is very mild to the point where the pressure in the right side isn't technically sufficient to overcome the pressure in the left side. So it will still be an acyanotic problem. But in severe cases where the narrowing becomes very severe and the infundibular narrowing or the subpulmonary narrowing or stenosis becomes very high, the pressure in the right side will exceed that of the left side, and so the blood will start to go from right to left. Again, the pressure here would be higher than in the left side, and so in turn the blood will go from right to left. And this is what we call a cyanotic problem, mainly because of what? The pulmonary stenosis. Now, as we said, the large VSD will not cause any sort of murmur, but what will cause an abnormal sound is the pulmonary stenosis. The valve is very narrow and very closed that it will not produce any sounds, and we will only hear an S2 sound because of the closure of the aortic valve. The pulmonary valve will not cause any sounds. Now, the cyanotic spills, basically it happens usually in kids when they're initially born. You'll start to see their extremities or their fingers, their lips, their skin are bluish in color. This is again because of the cyanosis. And usually kids, as a compensatory mechanism or something to relieve it, what they do is they do squats, or basically the knees they flex them and they bring them up to their chest. Why is that done? It's just basically a way to increase the peripheral resistance. Why is that? Basically, it's the idea that we know that the reason that tetralogy of Fallot happens is because the pressure in the right side exceeds that of the left side. So a means of treating these cyanotic spills is to increase the pressure in the left side so that the blood isn't going from right to left. So squatting, what will it do is you're compressing on your peripheral vessels, increasing the resistance, and so it's making it harder for the blood to go from the pulmonary side or from the right side to the left side. So in turn, this will cause less of shunting, and so there's less cyanosis. Other means to treat the cyanotic spills would be to give oxygen or even to give beta blockers to dilate or relax the infundibulum and the stenotic area. Now, in people or in children with the tetralogy of Fallot, sometimes they present with cyanosis and with fever. Why is that? This is usually associated with brain abscess. Now, as we know, the brain usually depends on glucose and depends on aerobic metabolism to break down glucose and get its ATP. Now, in cases where there is deoxygenation and there's low supply of oxygen to the brain, usually this will cause anaerobic bacteria to proliferate, and so the tetralogy of Fallot will present with cyanosis and brain abscess, which will cause the fever to be present. So usually those might be seen in certain individuals, in certain infants. They will also present with brain abscess because of the low oxygen that goes to the brain and the cyanosis that is resulting from the defect. Now, investigations, as we saw, an X-ray will show us the ventricular hypertrophy, and this will appear as a boot-shaped appearance, and this is a very distinguishable and indicative feature of tetralogy of Fallot, and an echo obviously is always important to look and diagnose. Treatment-wise, prophylaxis is very important to give for infective endocarditis. Now, for surgery, it could either be a palliative surgery or a palliative repair or a definitive repair. The reason we do palliative repair is usually in individuals or in infants that don't have a very stable situation, and you cannot do a definitive repair as of yet. So we opt for a palliative. Palliative is usually done for only 6 months. What is done is a shunt is placed so that blood goes to the pulmonary side, and so you have more blood going into the lungs, and ultimately just oxygenating and giving blood to the lungs. But excessive use of this shunt, or if the shunt is put for a really long time, it might cause pulmonary hypertension. So this is only usually done for 6 months, and then a definitive repair is done. A definitive repair, basically what you're trying to do is to correct the problems that we see. So we said you have a large VSD, so you're closing the VSD, trying to open up the pulmonary artery and the stenosis that we see and so on, just to reverse what is seen. So again, tetralogy of Fallot is a cyanotic problem. It's the most common cyanotic congenital heart disease, and it's characterized by the large VSD, overriding of the aorta, the right ventricular hypertrophy, and most importantly, the pulmonary stenosis. Okay, moving on to the last part of embryology. So we started off when we're looking at the heart tube. There were 2 tubes, they fused, and then you have the primitive ventricle in the cranial aspect and the primitive atrium in the caudal aspect, and then different constrictions caused different chambers to be present, and then it folded and you have the U-shaped and the S-shaped of appearance of the heart. And we went through the sinus venosus, then the primitive atrium, and then the primitive ventricle, which gives the rough inflowing part of the ventricle. Now we need the smooth outflowing part of the ventricle, the semilunar valve formation, and then finally the formation of the aorta, or specifically your ascending aorta, and the pulmonary trunk. So the bulbous corpus, which is basically the continuation of the primitive ventricle, will mainly give us in the caudal end the smooth outflowing part of both the right and the left ventricle, and then the most cranial part of it, or the most superior part, will be giving us the valves. So to look at the caudal part, which is the part that's continuous with the primitive ventricle, what happens is 2 bulbar ridges will appear. A right dorsal ridge and a left ventral ridge will appear, and then they will fuse together, and so it will divide the bulbous corpus into an anterior part and a posterior part. The anterior part is the part that will correspond to the smooth outflowing part of the right ventricle, which is the infundibulum, and then the posterior part will correspond to the smooth outflowing part of the left ventricle, which is the vestibule or the aortic vestibule. So the most caudal part of the bulbous corpus will give the smooth outflowing parts of the ventricle, anteriorly infundibulum and posteriorly vestibule. The most cephalic part is going to give us the valves, and the continuation, which are going to be the vessels, are going to come in the truncus arteriosus. So what happens is the most cephalic part will have 4 endocardial cushions forming, an anterior, posterior, and right and left. The right and left will continue to grow towards each other till they fuse, and then they will give us a posterior and an anterior orifices, or basically your posterior, which is the aorta, and an anterior, which is going to be the pulmonary valve. Now, the anterior and posterior will not grow towards each other. The only ones that will grow are the right and left. And so when we're looking at them, you will see that this is the aortic valve and this is the pulmonary valve. And you will see that the pulmonary valve will have 1 anterior cushion and 2 posterior cushions, endocardial cushions, whereas the aorta will have 2 anterior and 1 posterior. And then these cushions are what are going to correspond to the cusps, since both semilunar valves are tricuspid. But the orientation or the shape of them isn't the same that what we see in a normal human heart. In a normal human heart, the pulmonary is supposed to have 2 anterior and 1 posterior, and the aortic valve is supposed to have 2 posterior, and 1 anterior. So opposite to what we see upon the formation and the orientation. So what happens is they will both turn 45 degrees to accommodate for the orientation that they're supposed to have in a normal heart. So again, bulbous coitus, what happens in the caudal end is different than what happens in the cephalic end. The caudal end will just give us right and left bulbar ridges divided into anterior infundibulum and posterior vestibule, which are basically your smooth outflowing parts. In the most cephalic part, the part that's going to be continuous with the truncus arteriosus, the valves are going to form. 4 endocardial cushions will appear. The right and left will fuse or grow towards each other, and to give us a pulmonary part anteriorly and an aortic part, or an aortic valve posteriorly. And then to correct their orientation, they will both turn 45 degrees to have the orientation we see in a normal human heart. Now, moving on to the truncus arteriosus. Truncus arteriosus is the part that will continue growing out of the bulbous coitus to give us the great arteries, both the pulmonary trunk and the ascending aorta. What happens is 2 bulbar ridges will also grow from the most cephalic part, a right and a left. The right will grow distally and towards the left side, and the left will grow distally towards the right side. So what this will form is a septum. But this aorticopulmonary septum, so this is basically the truncus arteriosus is what's giving us the pulmonary trunk and the ascending aorta. So the name of the septum is basically what's telling you what's coming out of it, aorta and pulmonary trunk. And this septum spirals at 180 degrees. It's not going to be a straight line. So the spiraling is different in the caudal, giving us different orientation in the middle and then different in the cranial part. What happens in the most caudal part, the lower part, the septum will start off in a transverse orientation. It's horizontal. It will basically give us anteriorly the pulmonary trunk and posteriorly the ascending aorta. Then it will spin around or spiral to give us a anteroposterior septum, to give us the pulmonary trunk on the left side and the ascending aorta on the right side. And in the most cranial orientation, it will go back to being horizontal or transverse, but the ascending aorta will come anteriorly and the pulmonary trunk will go posteriorly. So the spiraling is what gives different orientations in the heart, and this is how the arrangement of the great vessels are. Most caudally, you will have the pulmonary trunk is anterior, the aorta is posterior. Then they will come side to side. Pulmonary trunk is left and aorta is right. And pulmonary trunk will be posteriorly in the most cranial aspect, and the aorta will be most anterior in the cranial aspect.
And finally, our final congenital anomaly of the day, which is going to be a cyanotic one. It's the transposition of the great vessels, which is also going to create a right-to-left shunt. Now, the transposition of the great arteries is basically the anatomical reversal of the aorta and the pulmonary artery. We all know that the aorta is associated with the left ventricle and the pulmonary artery is associated with the right ventricle because of their anatomical structure and their nature, in which each one of them is suitable for the amount of pressure, the force, and the resistance each circulation is part of. However, what happens in the transposition of great arteries is that these 2 vessels are going to switch, and it's basically due to the failure of the spiraling of the aortopulmonary septum, which is the septum right here, which is supposed to allocate at the end the pulmonary artery into the right ventricle and the aorta to the left ventricle. However, during failing of the spiral, what happens is that the aorta is going to end up with the right ventricle, and the pulmonary artery is going to end up with the left ventricle. This is going to result in a complete 2 parallel circulations in which the lungs is just going to keep on receiving oxygenated blood, and the extremities and the other body parts are going to receive deoxygenated blood. It is a fatal condition unless there's a mixing that is going to occur by an intercardiac shunt, whether it was a patent foramen ovale, ventricular septal defect, atrial septal defect, or by an extra cardiac connection, which is basically the persistent ductus arteriosus. I think it's a great point for us to kind of look at how Qudrat Allah subhanahu wa ta'ala, in which the ventricular septal defect, atrial septal defect itself, as discussed by Jenan, it's a problem. However, here it's a saving condition. So if the baby was not born with any of these defects in accompanying the transposition of the great artery, he's gonna die within minutes. And I think it's just an amazing thing to appreciate. Then moving on to the clinical findings, because there are going to be 2 parallel complete to parallel circulation, in which again the lungs are going to keep on receiving oxygenated blood, and the child, or the like upper and lower limbs, they're going to receive deoxygenated blood. There is going to be postnatal cyanosis that is not affected by the exertion or supplemental. They're going to have tachypnea, and upon the cardiac examinations you can hear a loud S2 sound, which is like comes in single, and there's going to be obviously a heart murmur. Then, if we were to do further investigations, such as a chest x-ray and an echocardiogram, we would find that there is a parallel double barrel, and on the chest x-ray, radiologists like to call it egg on string. To me, it's more like a potato on a string, but we have to go with what they said. And basically, this condition, initially, it's like an emergency case, but if there was not a shunt, like the baby was not born with any of the intracardiac shunt, we would have to induce a shunt by giving them prostaglandin E1. Prostaglandin E1 is going to keep the it's going to keep the ductus arteriosus open, and this way we're going to create some sort of a shunt in which a minimal amount of oxygenated blood get mixed with the deoxygenated blood, which could be like minimally vital to save the organs. Then this baby should undergo a definite surgical correction, in which if it was we're just going to switch the places of the arteries and return them back to the normal, by which the aorta goes with the left ventricle and the pulmonary artery goes with the right ventricle. And this concludes the end of our video for today.